Live from Boston, my name is Emilio Madrigal. Today is December 18, 2020. I'm joined remotely by my good friend and colleague, Rafat Manan, who is at UPenn in Philadelphia. Today, we're very happy to continue the Poem Path Pathcast series, the approach to non-neoplastic lung pathology that's being delivered by both Dr. Thomas Colby and Kevin Leslie. This is lecture number 4 in that series, and it's titled ILD with Airway, Centering, and Bronchiolitis. It's being delivered by Dr. Colby today with commentary by Dr. Leslie. As always, please feel free to post comments and questions in the Facebook and YouTube chat windows, and we'll make sure to pass those comments and questions along to Drs. Colby and Leslie at the end of the session. So with that short introduction, I'll turn the microphone over now.
Okay, thank you. It's good to be here this morning. I'm in sunny Arizona while other parts of the world have some snow, and Kevin is waiting to get in, by the way. I got a text from him. The 4th lecture in this non-neoplastic lung disease series is about interstitial lung disease that centers on airways, ILD with airway centering, and on bronchiolitis and the overlap between those two. The format will be as before, with case presentations along the way, a discussion of airway-centered interstitial lung disease, a discussion of bronchiolitis, and with specific discussion of the entities that are listed there on the bottom. These will all be available in the PDF handout that you can have available after this lecture. Here again are some of the entities to be discussed. I won't list these, but this is just for your information to see what's in this presentation this morning. A couple of references at the bottom. There are general references, and then there are other references on certain slides throughout the lecture, which you can then go to specifically if you want to. So let's talk about, again, pathologic diagnosis of non-neoplastic lung disease, and that requires an integration of information from what we have called these 4 domains: the clinical history, the laboratory history, the radiologic findings, the pathologic injury pattern, and then the individual disease entity that appears to fit best with those 3 things, A, B, and C. And then, of course, you have to know what the clinical question is. When you have a lung biopsy, or any biopsy for that matter, what is the question that you are answering with the biopsy? If it's a mass, obviously, what's the cause of the mass? But with interstitial lung disease, there can be a number of changes present in a biopsy that may or may not be significant. So you always want to know, what is the question I'm answering? Why is this patient coughing? Why is this patient short of breath? If there's an incidental tumor there, that may be not relevant to the reason that the patient ultimately had a biopsy. Bronchiolitis versus a bronchiolocentric interstitial pneumonia or bronchiolocentric interstitial lung disease. Here is bronchiolitis. It happens to be in a patient with inflammatory bowel disease, and it's obvious that the pathology there all centers on an airway, cut longitudinally on the left and in cross-section on the right, and the alveoli around that airway are almost entirely unaffected. That's easy at low power to appreciate that the pathology centers excuse me, on the airway, hence bronchiolitis. But what about this case? This is a bronchiolocentric interstitial pneumonia. This is hypersensitivity pneumonitis. Why is this an interstitial pneumonia? Well, part of that is due to the fact that clinically this patient has an interstitial pneumonia. Pathologically, you can see that not only is the airway involved, but some of the surrounding alveoli are affected as well. So that then on the left-hand side, you can see that most of the inflammation is centrilobular with sparing of the pleura, but the inflammation does trickle out into the alveoli around that. Similarly, on the right, in this example of peribronchiolar metaplasia, there is abnormality to the airway and then involvement of the airway around that, the alveoli around that airway. As you can imagine, there's going to be overlap between these things. The distinction is not always straightforward, and it differs with the modality of assessment. For example, a clinician may worry about bronchiolitis, yet a radiologist says, no, the radiology looks more like an interstitial pneumonia, and so on. There's not always a good correlation between clinical, functional, radiologic, and pathologic changes that would separate bronchiolitis from a bronchiolocentric interstitial pneumonia. And it is important that we as pathologists appreciate this overlap so that we can understand some of the differences in the modalities and how one may point toward airway disease and another point toward interstitial lung disease, or an overlap of the two. I will discuss these separately for the sake of simplicity, but I would reiterate that there's considerable overlap between what we call bronchiolitis and what we call a bronchiolocentric interstitial pneumonia or bronchiolocentric interstitial lung disease. Here's an example. Here's a CT scan on the left-hand side, and clinically this might be considered interstitial lung disease. There's lots of little spots and lines in that cross-section of the lung. Yet pathologically, virtually all the pathology there is limited to the airways and the immediately surrounding regions, with almost complete sparing of the alveoli away from the airways. There's lymphoid hyperplasia with germinal centers, and there's granulomas, and this is follicular bronchiolitis in a patient with Sjogren's syndrome. By the way, I just heard from Kevin. I guess he still can't get in, some technical glitch. Well, let's go to a diagram then. Central lobular injury. What do we mean by central lobular injury or a bronchiolocentric injury? Here is a schematic of a lung biopsy on the left-hand side, and central lobular regions are going to be away from the pleura, obviously because of the anatomy of the airways. But not only are bronchioles included in central lobular injury, but also alveolar ducts. Those are both part of a bronchiolocentric process. That's why some people would prefer the term airway-centered rather than bronchiolo-centered, because alveolar duct centering is still an airway-centered thing. Why is that important? Well, not surprisingly, if you have bronchiolocentric injury, it may very well be due to something that you are inhaling. And where that noxious substance meets the lung tissue in the small airways and the alveoli, that's where the injury is going to be seen. So this is obvious with infection. And early on with this COVID pandemic we have right now, patients have airway-centered injury, and then that may progress to more diffuse lung disease. Cigarette smoking, an extremely common cause of bronchiolocentric injury. Respiratory bronchiolitis-associated interstitial lung disease, pulmonary Langerhans Cell histiocytosis are both central lobular processes. Organic antigens that you're allergic to, which are the cause of hypersensitivity pneumonitis, is an airway-centered process. Pneumoconiosis, dust inhalation, also early on are airway-centered processes. So airway centering is an important thing to see in a biopsy and to appreciate in a biopsy, because it may help you learn something about the etiology. First, let's talk about hypersensitivity pneumonitis. There's non-fibrotic and fibrotic subtypes recognized nowadays. This is interstitial lung disease caused by the inhalation primarily of organic antigens in a susceptible individual. Not everybody that's exposed to these antigens gets these diseases. You need to be susceptible. Some of the best known are bird fancier's lung and farmer's lung. It's the antigens in the bird feathers and the bird feces that people react to, and it's the organisms that grow in the hay that the farmers react to. But there's other more interesting causes, such as hot tub lung, where antigens growing in the water itself are aerosolized, and you can see how easy it would be to breathe in all those antigens, particularly when you're drinking beer and yelling at each other. And there is a long list of very colorful names and causes for hypersensitivity pneumonitis, not the least of which is rat urine and rat serum. I'm not sure who is going to be exposed to those, perhaps in the laboratory setting, but I would try to avoid those if I were you. Hypersensitivity pneumonitis, fibrotic and non-fibrotic types. This is one of those diseases where bronchoalveolar lavage may be important because it can show a lymphocytosis, usually over 20%, and that's a useful clue. In the US, not a lot of pathologists deal with BAL specimens looking for lymphocytosis, but in other parts of the world, this is an important study. We are dealing primarily with histopathology, and the histopathologic features of hypersensitivity pneumonitis can be summarized as bronchiolocentric. Remember, this is an inhalational process. There's a cellular reaction. There's a granulomatous reaction reflecting a type 3 hypersensitivity reaction, and then there may be or may not be organizing pneumonia and some fibrosis. So here are the two main things that you're going to look for at low power: a bronchiolocentric inflammatory process in a biopsy. So you can appreciate this in a cryobiopsy, and sometimes even in a big transbronchial biopsy. In addition to an inflammatory centered process, you're looking for granulomas, and these tend to be small, loose granulomas, sometimes just clusters of giant cells. Here are some other cases. On the left, emphasizing the character of the granulomas. They're small, loose granulomas, and they're occurring in a background of a fairly dense lymphoid infiltrate typically. They're not the dense, tight, coalescing granulomas of sarcoid. They're really quite different. Granulomas are not always present. Sometimes there's just an inflammatory infiltrate, and this may have the appearance then of a cellular or fibrotic nonspecific interstitial pneumonia. About 3/4 of cases of hypersensitivity pneumonitis that we see pathologically will have granulomas. Over time, hypersensitivity pneumonitis can become fibrotic, and in some patients it produces a usual interstitial pneumonia pattern, a UIP pattern, including fibroblast foci. So similar to other chronic fibrosing lung diseases, in particular idiopathic pulmonary fibrosis. In a chronic process, there are certain clues that you can look for to make you think about hypersensitivity pneumonitis. Away from the scarring, you can look for more cellular regions, which are not typical of idiopathic pulmonary fibrosis. You can look for airway centering away from the dense scar. And of course, you can look for granulomas. Those all could be clues that you're dealing with a fibrotic lung disease that is not idiopathic pulmonary fibrosis, but hypersensitivity pneumonitis, mimicking idiopathic pulmonary fibrosis with significant scar. Remember that in medical lung disease, the radiologist is your friend. The radiologist can often help with diagnoses, and in the setting of hypersensitivity pneumonitis, the radiology is distinctive. In some cases, there are central lobular nodules here circled on the left. Other cases show air trapping, and that's thought to be a reflection of pathology of the airway producing some obstruction in some lobules, but not others, hence the pattern mosaic air trapping. Most inhalation diseases have an upper lobe distribution. Pneumoconiosis is an example, smoking-related lung disease is an example, and hypersensitivity pneumonitis is also an example where the radiologic changes are more severe in the upper lobes. So let's talk about a case. You have a biopsy and you look at that biopsy and you see an inflammatory process that shows some vague central lobular accentuation. There's a little more inflammation centrally than peripherally in that lobule, and you find small, loose granulomas. Morphologically, that is typical non-fibrotic hypersensitivity pneumonitis. So that's your pathologic injury pattern. Now, in such a case, classic exposure or classic radiology may not be present, and the pathology, the diagnosis is driven by the pathology because the pathology is so distinctive. Well, in not all cases is the pathology that distinctive. You can imagine another scenario where your biopsy does not show classic hypersensitivity pneumonitis. You just have a cellular interstitial infiltrate that could be due to lots of things, or you might even have a fibrosing pattern with honeycomb change, usual interstitial pneumonia that might or might not be due to hypersensitivity pneumonitis. In a case like this, where the biopsy is not quite classic, you need compelling clinical bronchoalveolar lavage or radiologic findings. When they are present and support a diagnosis of hypersensitivity pneumonitis, then the final diagnosis that the patient has is driven by the clinical and radiologic findings, remembering that the pathology is non-specific, but still consistent with either fibrotic or non-fibrotic hypersensitivity pneumonitis. So how common is fibrotic HP? Well, here is a study that I was involved with a number of years ago, looking at patients that were initially diagnosed with idiopathic pulmonary fibrosis. In other words, there was no identifiable cause. 46 consecutive patients that met the criteria for idiopathic pulmonary fibrosis were looked at, and 20 were reinterpreted as chronic HP as more information became available and as the pathology was reviewed. And what do you think was implicated in many of those cases? Feather bedding, feather pillows, and that sort of thing. And those of you that are listening right now may wonder, do you have a feather bed at home that could be a problem for you in the future? This study has been criticized. People have said the incidence is not that high, but I think the important point of this study is that whenever a diagnosis of idiopathic pulmonary fibrosis is made, assuming that it's idiopathic, there's always a possibility further on that some cause could be identified and the case might in fact be chronic hypersensitivity pneumonitis. It's been shown in studies that if you have hypersensitivity pneumonitis with fibrosis, your survival is significantly worse, fibrotic down here in the lower curve, significantly worse than non-fibrotic HP. And for that reason, clinicians now divide examples of hypersensitivity pneumonitis into fibrotic and non-fibrotic types in terms of clinical management. One of the common types of scarring that one sees in fibrotic hypersensitivity pneumonitis is peribronchiolar metaplasia. And you all should get comfortable with identifying what this is. It's a common finding in lung biopsies. When it's widespread, then you're usually dealing with an airway-centered process that is inhalational in cause. So the current guidelines, and these have just been out for a couple of months, the current guidelines for hypersensitivity pneumonitis are, clinicians divide them into non-fibrotic HP and fibrotic HP. And both the radiologists and the pathologist have criteria for what they would call typical, compatible with, or indeterminate for hypersensitivity pneumonitis. And these terms then provide a scheme for which clinicians can use to diagnose and manage patients. When we think of the classic histology of hypersensitivity pneumonitis, we're thinking of typical HP. But this paper is a useful paper to get ideas as to what is compatible with it and what is indeterminate. Now, indeterminate still could be HP pathologically if other findings such as exposure and radiology are classic. So I will stop for a second, let anybody make any comments. Kevin was having some issues getting into the call today. I'm not sure if he's in. Are you there, Kevin?
Yeah, can you hear me?
Yes.
Yeah, so that's a great exposition of the problem of airway-centered disease. You know, it comes to my mind that on the consult practice, we frequently would come up with an idea that a patient's disease was airway-centered, and discussions with the pathologist always came to the point of the pathologist saying, I don't get it. I don't understand how you came to this conclusion. So in your analysis, as you said, identifying the airway-centered nature of a disease is difficult. And there are a few clues that we generally use. If you're not sure if it's airway-centered, as you said, look for the artery. The artery and the airway travel together. So a muscular vessel in the lung is an artery until proven otherwise. So if you look for the arteries and you see disease is always near the artery, it's likely an airway-centered disease.
Okay, I will move on. We will have questions at the end, by the way. Now we come to pulmonary Langerhans cell histiocytosis, and this is a wonderful disease. Most of these are smoking related and hence have an upper lobe distribution and often show airway centering early on before there's too much lung destruction. And then the distinctive cell that we see in Langerhans cell histiocytosis is, of course, the Langerhans cell. Now, I grew up before there were immunostains, so I feel pretty comfortable identifying these cells based on their distinctive nuclear cytologic features compared to a normal alveolar macrophage right there on the left. But most of you are going to do, and I do as well, immunostains to confirm the identity of Langerhans cells, and you all know CD1A, S100 Langerhans, and I think there's some other ones as well. By the way, a lot of these cases have a BRAF V600E mutation, even those that are thought to be, quote, reactive and related to cigarette smoke and may not be clonal when one looks at multiple nodules in the lung. The early lesions here are airway centered, and this is highlighted with an alveolar duct and a CD1A stain showing the proliferation of Langerhans cells around that alveolar duct. And that's thought to be due to, say, an influence of cigarette smoke that in certain individuals causes Langerhans cells to proliferate beyond just a reaction. PLCH, inhalational etiology, airway center distribution, upper lobe predominance. So here is a montage showing a low power, and this is typical of what you see in Langerhans cell histiocytosis on the left. You can see multiple nodular lesions. Some of them may be fibrotic. Some of them are more cellular. In the cellular ones, you'll identify the Langerhans cells. And if you look carefully, you can see that some of these nodules are airway centered, but as they get bigger, that is harder and harder to appreciate. Although this nodule here seems to spare the pleura, probably centers on an airway. And this nodule, this fibrotic nodule on the right, you can actually see the airway in the middle of it branching right at that point with scarring around it. This image also highlights what happens in this disease. There's an early cellular phase and then a later fibrotic phase, which may or may not have cavitation. And the cavitation and nodularity are the key features that the radiologist looks for, along with the upper lobe distribution. This disease has a natural history. The lesions become fibrotic, and finally, they leave stellate centrilobular scars, and the Langerhans cells are completely gone. So in such a case as this, you can't do an immunostain to confirm the diagnosis. You have to know something about the distribution of the process and the character of the scarring. And a stellate centrilobular scar, like you see in these two images, does not usually get caused by most other fibrotic lung diseases. This is very, very typical of healed or late PLCH. So let's go back to a case evaluation. You have a biopsy from a case and you have identified the unique histology of PLCH. Or you just see a scarred phase with no Langerhans cells. How are you going to deal with those two situations? Most of these are smokers, and most of them have typical radiologic findings, and those features are going to help you in your diagnosis. In the case of the active phase, you can make a definitive diagnosis based on the identification of the Langerhans cells. If there's no Langerhans cells there, but you have these other typical features along with the stellate centrilobular scars, a diagnosis of consistent with PLCH in the later phase is appropriate. Well, I want to move on to another inhalational disease. This is a unique thing. It's relatively uncommon, but I want to use it to emphasize you identify centrilobular distribution at low power. On the left-hand side here, you can see these inflammatory regions scattered around that appear to spare the pleura. And in some, you can identify a pulmonary artery and know that this is an airway. And this is an airway here with a pulmonary artery next to it. Same thing down here, you can actually see a little bit of the bronchiole. This is a bronchiolocentric lesion, and you pick it up at low power. If you go to high power, you're going to lose the panoramic view. You're going to lose the ability to pick that out. Here's another case, a different case. Again, there's relative sparing of the pleura, and even though it's a little hard to make out down here, this is most likely centrilobular, mainly because it spares the pleura, and it's a nodular lesion. The distinctive thing here, of course, are the giant cells. And the giant cells are profuse in this, and you can actually see them In the right-hand low-power image, you can see lots of alveolar giant cells. This is what was originally called giant cell interstitial pneumonia. We now recognize it as an interstitial lung disease related to cobalt, hence a form of pneumoconiosis, although it's not really a dust, it's an allergic reaction, a hypersensitivity reaction to the cobalt itself. Giant cell interstitial pneumonia, a unique centrilobular interstitial lung disease. Hard metal pneumoconiosis is another name for that because many of the exposures are due to hard metal, and hard metal has cobalt in it as part of the process to make hard metal. It has unique hardness. Tungsten carbide is something you might hear about, that's something somebody's exposed to, but it's the cobalt in the tungsten carbide that's implicated as the cause of the interstitial lung disease. And in certain factories, an appreciable percent of patients that are exposed may have evidence of interstitial lung disease. Typical occupations include grinding of metals, drill bits, grinding wheels, etc., diamond polishing, paint and pigment that has cobalt, oil and chemical industry, and jet engines, but hopefully your clinician will be the one that will ferret out that exposure and not you. So let's review, going back a couple of lectures, to the idiopathic interstitial pneumonias. These are the things that are generally taught, and you all learn about UIP, NSIP, RB, ILD, etc. Currently, these are divided into the major idiopathic interstitial pneumonias, the minor idiopathic interstitial pneumonias because they're considerably less common, and then there is, of course, an unclassifiable category. Well, why do I bring this up for review? Remember, the most important lesion here among these idiopathic interstitial pneumonias is idiopathic pulmonary fibrosis, which has the pathologic injury pattern of usual interstitial pneumonia. So here is a case. This is a case presentation. What do you see here? You see a lot of pink, so there's a lot of fibrosis. The fibrosis is patchy because there's some normal alveoli left behind. And there's fibroblast foci, and there's a little arrow right there pointing to a fibroblast focus. So morphologically, that field has all the diagnostic features of usual interstitial pneumonia, UIP type fibrosis. Well, when we get a biopsy, we have to look at all the slides, don't we? We can't just look at one area. We have to look at the whole area and put it all together. This is the same case, another field in the same case. And I would ask, do you appreciate centrilobular lesions in that right-hand field? There's pleural sparing. There's normal alveoli between the pleura and these regions of abnormality near a bronchiole there. A little hard to tell there. This is a bronchiole right here. So these are bronchiolocentric. There is bronchiolocentric scarring. What does that mean in the case of a lesion, a biopsy that otherwise in other areas shows usual interstitial pneumonia? So you could ask yourself the question, in that list of the idiopathic interstitial pneumonia, should there be an idiopathic bronchiolocentric interstitial pneumonia? And there's some papers that I won't spend a lot of time going over of idiopathic bronchiolocentric interstitial pneumonia that has been suggested in the pathology literature that there may be such an entity. Unfortunately, 3 different names were given for these, and I won't bore you with going over those names. This is from reference 1. Here is a process that shows prominent peribronchiolar metaplasia, a feature of centrilobular scarring. So is there an idiopathic disease that causes centrilobular scarring like this that we could put in that list of idiopathic interstitial pneumonias? And the biggest paper that really looked at this is one that Kevin was involved with, looking at, in this paper, was called Airway-Centered Interstitial Fibrosis, Etiology, Clinical Findings, and Prognosis. 68 patients with airway-centered interstitial fibrosis among about 600 biopsies, surgical lung biopsies for interstitial lung disease. All of these had airway-centered fibrosis. Nearly all had airway-centered inflammation and peribronchiolar metaplasia. Here is an image from that paper on the right showing an airway-centered scar. And here is from another case, just to reiterate, peribronchiolar metaplasia, or PVM, where the main pathology centers on the airway and the surrounding alveoli, with some fibrosis and metaplasia, bronchiolar metaplasia. Well, in this paper, 68 cases, here is the presumed etiologies for those 68 cases: 29 HP, 18 GERD or aspiration, 4 connective tissue disease, and only 2 out of the 68 cases did they think it could be idiopathic. So it will be a while before we add an idiopathic bronchiolocentric interstitial pneumonia to that list of the, quote, idiopathic, or the IIPs, the idiopathic interstitial pneumonias, the UIP, DIP, etc. So as a pathologist, if you're looking at a biopsy and you think you have a central lobular process and you can't put it into some of the other things we've been talking about, think about fibrotic hypersensitivity pneumonitis, correlating with this 29 cases in this study on the left-hand side, or aspiration, where GERD and aspiration would be the presumed proximate cause of the interstitial lung disease. Those would be the 2 things to think about. That we'll come back to aspiration a little bit later. Let's look at this case. What do we have here? We have peribronchiolar metaplasia, something that all of you should be able to recognize. Number one, to be able to name it. You can call it Lambertosis or some other name if you want. Peribronchiolar metaplasia is the one that's most commonly used. Suggests airway-centered scarring, and then that will narrow down your differential as what to look for. Well, in this case, there's a small granuloma. So airway-centered scarring and a granuloma in an interstitial lung disease should make you think of hypersensitivity pneumonitis. That's most likely what is going on. Obviously, then what your pathology report, your pathology findings will then be correlated with what's going on clinically, and the clinician will come up with the disease entity that fits. But pathologically, airway-centered process with scattered small granulomas, fibrotic hypersensitivity pneumonitis would lead the list. Kevin, any commentary on this stuff?
Yeah, thanks, Tom. This is it's an interesting problem, and I think we've emphasized it throughout this course. Is, we in pathology, our dominion is the microscope, and I think many pathologists during their careers get to a place where they say, well, the buck stops with me. I have the microscope. I have the final answer. And I think the most frustrating thing for pathologists trying to learn about ILD is letting go of that notion that you are in control of the process. As you've emphasized, Tom, we are one critical piece that only has validity when we integrate our findings with the clinical and radiologic presentation. So I think your presentation has really nicely outlined that issue. And I think no one listening to this presentation should be concerned about offering up a differential diagnosis in your diagnosis field. Fibrotic airway-centered disease with small granulomas, fibrotic hypersensitivity pneumonitis leads the differential diagnosis. Other things to consider, and then put a couple things in there, because a number of times when 6 months later we get a call back on a case and they say, actually, it ended up being a different disease with fibrosis around the airways and granulomas.
Yeah, I think that's a good point. We have to let go of the fact that we're the final answer in some of these cases. We're a piece of the data, and we're not the final answer. Well, we do come to aspiration now. Aspiration is a common thing. Yours truly has aspiration every once in a while. Aspiration can produce a localized mass, an interstitial lung disease, or a bronchiolitis, or everything in between. And in this study from Mukhopadhyay in 2007, we can get some information about that. 59 cases of lung disease due to aspiration of food or other particulates. And in all of those cases, the food or other particulates was identified in the biopsy. These patients had the usual symptoms of lung disease, including recurrent pneumonias, but I would highlight the radiology. Bilateral infiltrates were present in 50%. And in some, they could be diffuse. In other words, aspiration can cause interstitial lung disease. We think of it as a localized mass or abscess in the superior segment of the right lower lobe. That's the most common place. But depending on somebody's position when they aspirate, they can aspirate all over the lungs and they can get diffuse lung disease. Hence, these patients will come to biopsy with a diagnosis of interstitial lung disease. So here's a couple of cases. On the left, you see aspiration with Apache organizing pneumonia. And remember, it's easy to identify these edematous, ramifying intraluminal polyps of fibroblastic or granulation tissue as the key feature of organizing pneumonia. On the right, the manifestation of aspiration is as either an acute or a chronic bronchiolitis. And in both of these cases, you can find degenerate food. Now, I know that it's easy to miss degenerate food because I can look back at cases that I saw years ago and see that I clearly missed it. So you have to specifically think about food and you have to look for it. And what does it look like? It looks like a pink glob of degenerate stuff that you might think, well, maybe it's a parasite. The key is that it doesn't look like a normal structure that you'd find in the lung. The one thing that looks a little bit like it is a corpora amylaceae, but corpora amylaceae are smooth and more eosinophilic. Often with degenerate food, you can see a little bit of deteriorating structure in the center of it. There may be a giant cell reaction around it. But I would emphasize that you need to look for it. It's easy to miss, and I know I've missed it multiple times. Sometimes you will actually see the cell walls of perhaps a piece of celery here, in this case, with a giant cell reaction around it. Patients who aspirate tend to be older. They tend to be on lots of pills, and finding a piece of a pill in the lung is not that uncommon, and you may find birefringent material. Now, sometimes polarizing a slide is useful to screen for polarizable foreign material, but not all aspirated material is birefringent. This piece of vegetable on the left-hand side was not birefringent. So if it's present, if birefringence is present, it's helpful, but its absence does not exclude aspiration. Aspiration typically is going to cause bronchiolitis, and if the reaction extends beyond the bronchiole, then it's going to be more of an interstitial pneumonia. Here, there's the bronchiolar involvement on the left, and then more distally, organizing pneumonia. And again, here is this degenerate food particle. It looks like a pink structure that is not anything normal in the lung. Sometimes vessels can look a little bit like it, and you may need to do multiple levels to confirm it. Sometimes aspirated material will be positive with GMS stain. Sometimes it's positive with a PIS stain, but mostly it's thinking about it and looking for it. Once you suspect you find it, then you can do some of those special stains. Aspiration is more often a bronchiolitis pathologically, but clinically it can resemble an interstitial pneumonia. Well, that brings us to bronchiolitis. And as I said, I'm going to talk about bronchiolitis and Bronchiolocentric ILD separately for simplicity, but actually there's considerable overlap. Here's your normal bronchiole on the upper right. What is bronchiolitis? Well, bronchiolitis is inflammation of the bronchioles. And you can see in some cases a cellular infiltration, like you see here, with or without fluid or mucus in the center. Notice that the lumen is pretty much intact there. There might be some metaplasia of the lining, but otherwise that's just a cellular inflammatory reaction, a cellular bronchiolitis. Well, as in any inflammatory process, in addition to a cellular reaction, there can be a mesenchymal reaction, fibroblastic reaction, and that fibroblastic reaction may be an intraluminal polyp, as you see here on the left, typical of a organizing pneumonia type situation, or the scarring can be between the smooth muscle of the airway and the epithelium. And this is what I call constrictive bronchiolitis, and this is the kind that's typically associated with obstruction. The clinical, radiologic, and functional effects of these lesions are going to vary enormously, and I'll hopefully show you some examples of that. Well, what are the small airways or the bronchioles? They are airways that are smaller than 2 millimeters. They are generally not visible on a CT scan, and if they are visible, then they're abnormal. And that CT scan in airway disease can be extremely useful. Here is an example of a CT scan where the small airways in the subpleural regions can be visualized. Why? Because they're abnormal. They have cells or fluid or both making the airways thicker and hence apparent on a CT scan. Here is a schematic highlighting what we are seeing. We're seeing abnormal peripheral airways in the peripheral lobules that are now abnormal enough to be seen on a CT scan. Why is that important? Because we see wedge biopsies, less and less these days, but we still see them. And we can see the same thing. We are seeing at the same level of magnification the small airways in a wedge biopsy that are present in a schematic in a lobule that are present in an actual CT scan of a patient. So there's a pretty good correlation there between surgical biopsy or autopsy and resection, of course, and what the radiologist sees. Well, I divide bronchiolar pathology into these groups, the ones where the cellular or exudative reaction dominates, the ones where the mesenchymal reaction dominates, and there's 3 different mesenchymal reactions. I've showed you the first 2, and the third one we saw earlier, peribronchiolar scarring. We'll talk about that a little later. Mixed patterns are actually most common, but in order to understand airway pathology, it's useful to divide it up into these categories to sort of understand them separately first. Cellular bronchiolitis, a cellular exudative reaction, is the dominant feature that can be an acute inflammatory, chronic inflammatory, or with follicular hyperplasia or mixtures of the above. And here is a nice example of a cellular bronchiolitis on the right-hand side. This case happens to be due to inflammatory bowel disease, but there's nothing very specific about that. All you can say is that's a cellular bronchiolitis, and the differential would include infection, aspiration without foreign material identifiable, connective tissue disease, transplantation, lung or bone marrow, IBD, and then of course there's going to be idiopathic cases. And this kind of bronchiolitis can be a component, a cellular bronchiolitis can be a component of RB-ILD or extrinsic allergic alveolitis, which is another term for hypersensitivity pneumonitis. Here are some examples. So COVID right now is causing a rampant cellular bronchiolitis in some patients, and in some it gets a lot worse. Respiratory syncytial virus is a good cause of a cellular bronchiolitis, and if you're lucky, you can see the little cytoplasmic eosinophilic inclusions. Adenovirus produces a necrotizing cellular bronchiolitis, and again, if you're lucky, you can see the inclusions. And here is a case of mild influenza, H1N1 influenza. The tissue was taken out for some other reason, but the patient was known to have influenza. And this is what we all have when we get a viral infection of the lung. Influenza, for example, there's a mild cellular bronchiolitis, as you see here on the right, mild acute and chronic inflammation, and some metaplastic changes. Inhalational process, airway injury is the key manifestation. Mycoplasma pneumonia is another good cause of a cellular bronchiolitis. There's nothing very specific about that. Again, you're going to say, okay, this is a nonspecific acute and chronic cellular bronchiolitis, and go back to that differential from the prior slide as to what the possible causes could be. Primary ciliary dyskinesia is a condition that predisposes people to recurrent bacterial infections, and it's no big surprise that the major pathologic findings then would be airway-centered inflammation secondary to bacterial infection, here an acute and chronic bacterial bronchiolitis. Nothing specific about it. The history is what helps make the diagnosis and cultures, of course. Well, not only acute and chronic inflammation, but granulomas can center on airways and produce a granulomatous bronchiolitis, as you see here. And this is an example of chronic granulomatous bronchiolitis due to atypical mycobacterial infection in a middle-aged woman. All examples of cellular inflammatory bronchiolitis, key feature at low power is being able to recognize that as a bronchiolocentric process. In fact, it's exquisitely centered on the bronchioles, and there's not really much happening to the alveoli around them. The HRCT in bronchiolitis is helpful. You saw that before. Abnormal bronchioles can be seen on a CT scan as central lobular nodules. Another key term that the radiologists use is a tree in bud pattern, because the branching abnormal airways can be identifiable all the way out to the periphery and literally look like a tree in bud. Radiologists nowadays is actually diagnosing bronchiolitis, and these cases are not coming to biopsy in many instances because the CT features are so distinctive. In some patients, there's a hyperplasia along the airways, a hyperplasia of the bronchus-associated lymphoid tissue, and the term for this is follicular hyperplasia, follicular bronchiolitis, and I showed you an example of that earlier. Generally, these are going to be connective tissue diseases, especially Sjogren's syndrome and rheumatoid arthritis, but there's some other conditions that may be associated with lymphoid hyperplasia, notably HIV. In the early HIV epidemic, a lot of the lung tissue that we saw showed lymphoid hyperplasia like this along the airways. And here's an example of follicular bronchiolitis in rheumatoid arthritis. You can see there's multiple nodules on the CT scan, and they seem to be airway centered, and that of course is because the inflammatory process with lymphoid hyperplasia is centering on the airways with relative sparing of the intervening alveoli. Well, let's move on now to the mesenchymal reaction. Any inflammatory process has a cellular reaction and has a mesenchymal reaction. Mesenchymal reaction number one is organization with intraluminal polyps, as you see here. Number two is subepithelial fibrosis and scarring with partial or complete luminal loss. And the terms that I like to use for these are organizing pneumonia for the first one and constrictive bronchiolitis for the second one. Both of these have been called bronchiolitis obliterans in the literature, and that term bronchiolitis obliterans is a little bit confusing, and you need to know exactly what the context is when you hear that term. Does that mean airflow obstruction, or does that just mean an intraluminal polyp? The original paper on bronchiolitis obliterans back in the 1800s actually was talking about these intraluminal polyps. Organizing pneumonia with intraluminal polyps is a common reparative reaction typically associated with interstitial or infiltrative lung disease radiologically. Constrictive bronchiolitis is uncommon. It's usually pure in that it's pretty much restricted to the airways, and these are patients that have obstructive lung disease and often irreversible obstructive lung disease. Just to remind you what happens in organizing pneumonia usually may involve a bronchus with an intraluminal polyp, but usually the process is most prominent in the alveolar ducts, as you see here. And it's a process that goes all the way out into the periphery, and recognizing and organizing pneumonia pattern is easy once you appreciate it with this edematous intraluminal fibroblastic tissue. This is the differential from prior lectures. When you see an organizing pneumonia pattern, what are the things that you should be thinking about when you're dealing with such a biopsy? Organizing pneumonia can be appreciated in tiny biopsies as well as big biopsies. It's a common feature. Well, let's move on to that other bronchiolitis obliterans that I like to call constrictive bronchiolitis. And the list of causes are shown here on the left. The case on the bottom is an example of transplant-related obliterative bronchiolitis or constrictive bronchiolitis. And the one at the top was an idiopathic case, didn't really find a cause. And I won't list all these. They're all relatively uncommon, but you should be able to have that list available when you're faced with a biopsy that appears to show luminal narrowing of the airways due to subepithelial scarring. If you're lucky, you get complete obliteration, as you see nicely on the EVG stain on the bottom. But actually, more commonly, you generally see partial obliteration, and that's what you need to learn to look for and appreciate. Constrictive bronchiolitis produces this expiratory pattern of mosaic perfusion, as you see here, and again, the radiologist is helpful in finding that, and often they will ask for expiratory CT scans to highlight this abnormality because it may not be so obvious in the inspiratory CT scan shown on the left. Well, what happens to bronchiolitis? All of us have had bronchiolitis, mild usually, and usually it goes back to normal. Some of us will develop a post-bronchiolitic asthma-like syndrome that may stick around for a while. Some of us may get some mild scarring, and a small portion of people with bronchiolitis will end up with some sort of severe scarring. So there's a lot of things that can happen to airways that are involved with bronchiolitis. Acute mycoplasma pneumonia on the left, as you see, typically resolves completely. But every once in a while, there's enough damage to produce a severe constrictive bronchiolitis, in this case on the right, highlighted with an elastic tissue stain, with complete obliteration of these small airways. And I can tell you a little anecdote about that case. That was the first case of constrictive bronchiolitis I saw as a resident, and I didn't appreciate those airways. Why? Because they were so inconspicuous on the H&E that they just looked like a little bit of fibrous tissue. Airway disease can be subtle, and you have to think about it and look for it because it's easily missed, as I did with this case on the right. Pathologic changes in the bronchioles produce clinically diverse syndromes, and distinction from interstitial lung disease may be difficult and arbitrary. I reiterate that again. We tend to separate these conceptually, but often they overlap. Here is a case where there's a bronchiole and there's a surrounding organizing pneumonia reaction. Clinically, this manifested as an interstitial lung disease, but the lumen was patent, and so there was no obstruction. And even though pathologically it's clearly an airway-centered process, this was an influenza bronchiolitis with some surrounding organizing pneumonia. In this case, incidentally, just melted away when they put the patient on steroids. Well, I want to finish up talking about the mesenchymal reaction in airway injury with mesenchymal reaction number 3, or peribronchiolar metaplasia, as you see here. And often in this kind of airway injury, the lumen is patent, so there's no airflow obstruction as a clue to the clinician or the radiologist that this is an airway-centered process. It's really only best appreciated pathologically, where the scarring clearly centers on the airway and the immediately surrounding alveoli. Here is another case nicely showing central lobular pathology with peribronchiolar metaplasia. Sometimes you can be concerned that it might be a form of adenocarcinoma, but finding cilia is a comforting feature to highlight that this is a benign process, as is, of course, the distribution. It's central lobular. A carcinoma would not tend to show that central lobular distribution. And here's a schematic of what's really going on here. The fibrous tissue here highlighted in blue in recognition of trichrome staining is around the bronchiole, not really in the lumen. So the lumen is patent, but the airway is going to be stiff. And with a stiff airway, then the lung is going to be stiff, and hence there's going to be increased resistance in the lung, and functionally can also look like interstitial lung disease or restrictive lung disease. Causes of peribronchiolar metaplasia are all the various things that you can think of that can injure the small airway, such as infection, hypersensitivity, pneumonitis, ILD, RDS, and often we will see a little bit of peribronchiolar metaplasia in a biopsy that may or may not be significant, and it appears to just be an incidental finding. And all of us have little airway injuries off and on, and a lot of those are probably subclinical and never really cause a problem. Here it is again, highlighting peribronchiolar distribution of the pathology, relative luminal patency with a proliferation of bronchiolar epithelium that might at first look like a tumor, but has cilia, and that's really a helpful finding. This is a residue of small airway injury that may or may not be a component of interstitial lung disease. So in summary, we have an inflammatory reaction in bronchioles that can be cellular or can be mesenchymal or a mixture of the two. And the mesenchymal reaction can be organization with intraluminal polyps, which is part of organizing pneumonia. It can be subepithelial scarring with luminal compromise and clinical obstruction and constrictive bronchiolitis, or it can be peribronchiolar injury with peribronchiolar metaplasia, which often manifests more as an interstitial process rather than airway disease. I wanted to make a few comments about chronic bronchiolitis in practice. Most of the cases are going to show a mixture. Here's a florid cellular bronchiolitis that also has subepithelial scarring and narrowing of the lumen by subepithelial inflammation. This is a case of inflammatory bowel disease, airway disease, where the patient had appreciable obstruction. So in bronchiolar pathology, when we go back to our 4 domains, this gets a little bit difficult. because the clinical and radiologic findings can be so diverse. There may or may not be obstruction pointing toward an airway process or interstitial lung disease or mixture of the two. Similarly, the pathologic injury patterns can vary from a pure cellular process to a pure mesenchymal process with lots of overlap and with or without luminal compromise. So hence, in the setting of airway disease, ascribing a clinical diagnosis is really of necessity multidisciplinary. You can't just do it based solely on your biopsy. You can have a pretty good idea, but this is a situation where you need a lot of good clinical radiologic correlation. And I'd like to finish up with a couple of comments about this disease. Does anybody know what this disease is? The left-hand side suggests it's a cellular bronchiolitis. The right-hand side shows the eosinophils and lots of goblet cells. And this, of course, is asthma. And we think of asthma as asthma and a totally separate entity, but in fact, asthma is really just a form of bronchiolitis and bronchitis that has the distinctive features of eosinophils, goblet cell metaplasia, smooth muscle hyperplasia, and it doesn't show in this image basement membrane thickening. But clinicians think of this as a different disease, but really it's a distinct form of bronchiolitis. The reason I mention asthma is that it's common. Yours truly has post-flu asthma every now and then when I get a case of the flu, but you may not have a history of asthma in a biopsy that you look at. And patients that have mild asthma are often asymptomatic in between episodes, so it's no surprise that sometimes you see normal airways in patients that have well-documented asthma. Sometimes you see mild changes such as little goblet cell metaplasia or a little bit of mucostasis in a patient who's otherwise relatively well with their asthma. So I will end there, and I thank you for your attention, and appreciate any commentary from Kevin, and we'll be happy to take questions.
Well, Tom, you know, as you were presenting on the small airways pathology, I was reminded of the fact that before COVID-19 took over the world, there was a minor epidemic in the United States, which ended last year, and that was E-Valley. And many of the listeners may recall this. This was electronic vaping associated acute lung injury, E-Valley. And it was discovered that the patients were vaping with material that had been contaminated. So once this was discovered and eliminated, the disease essentially evaporated and disappeared. The second point I wanted to make about peribronchial metaplasia is if you're in doubt because you have tremendous peribronchial metaplasia, you can always do a P40 or a P63 immunostain because these things light up with all the basal cells being positive, very helpful in addition to cilia.
Okay, I guess we can open up to questions as well. Excuse me.
Yeah, thank you so much, Dr. Colby, for this excellent discussion. I can see a few questions online. I will read them for you. So one question is lipoid pneumonia a common indicator for biopsy?
Is lipoid pneumonia a common indicator for biopsy? Well, my question would be, how do you know there's lipoid pneumonia if you don't have a biopsy yet? I think if there's a clinical suspicion of a lipoid pneumonia or exogenous lipoid pneumonia, that's typically a lower lobe process in a patient who has an exposure history. So lipoid pneumonia is something you could diagnose by bronchoalveolar lavage. You could see it on a transbronchial biopsy. Now, I'm separating lipoid pneumonia, which is due to exogenous lipid, from just foamy macrophages or so-called endogenous lipoid pneumonia, which is a very common finding that's seen in all sorts of lung diseases. A few lipid-laden macrophages are common and non-specific.
Thank you. So the next question I have is, someone is commenting that interstitial lung disease is indeed very difficult. And what is the difference between DIP and RBILP organizing pneumonia? I hope I got the question right.
Well, that's really actually a very good question because desquamative interstitial pneumonia and respiratory bronchiolitis associated ILD or RBILD are both smoking related. They show considerable overlap, and separating the two is probably not clinically relevant. I think if you have a smoker who has organizing pneumonia, then likely what has happened is that they've developed an organizing pneumonia. A CT scan shows an extensive infiltrate, and then the biopsy looks like there's both RB-ILD and organizing pneumonia. But in fact, what happens is this background smoking change in all smokers, and then when they get the organizing pneumonia on top of it, that brings them into the doctor, that brings them ultimately to biopsy. I think it's the organizing pneumonia that's the pathologic lesion, but the background smoking change can be quite extensive. So you might think there's to both conditions there.
Right. Thank you. There is the next question. The question is, does smoking cause bronchiolitis obliterans following chronic bronchitis? And what's the pattern there?
That's an interesting question. Does smoking cause bronchiolitis obliterans? And I assume what that question is coming from is, does it cause airflow obstruction in the small airways due to a constrictive bronchiolitis? And there are morphometric studies that show that the small airways become thickened in chronic smokers. And in that way probably does cause some obstruction, but I think the obstruction is more prominently due to the emphysema and loss of lung tissue, so the small airways are allowed to collapse when people exhale. So yes, we don't really see a severe constrictive bronchiolitis due to cigarette smoking, but there might be a mild constrictive bronchiolitis there along with emphysema, and the two together cause significant obstruction.
Thank you. The next question is it possible to diagnose bronchiolitis on transbronchial lung biopsy or cryobiopsy?
The answer is yes and yes. Excuse me. Obviously, with a cryobiopsy, you get a bigger specimen and you can get whole airways, and you can see all the abnormalities that I've shown you today, all of which came from surgical biopsies, of course. Obviously, with a cryobiopsy, it's smaller, so there's going to be fewer airways, so the sampling is less. But in the setting of transplantation of the lung, transbronchial biopsies have been used to identify what they call obliterative bronchiolitis for years. They tend to do lots of transbronchial biopsies, like 6 or 8 or 10 in a given case. But you can see them. All of that is predicated on whether or not you get pieces of airways. And the smaller the sample, the chances that you have airways becomes less and less. But the short answer is yes, you can see airway abnormalities even on a transbronchial biopsy.
Right. And here's another question for you, Dr. Colby. How much it is clinically important to accurately read the different patterns of bronchiolitis? For example, cellular versus organizing, as both patients will end up receiving steroids, and fibrotic is certainly a severe disease pattern.
Yeah, that's a good question. I think that the net effect may be the same. I presented these as separate things, cellular bronchiolitis and organizing pneumonia, et cetera, but really there's considerable overlap there. I think the key thing is if the observer can recognize this as the bronchiolocentric process, that's the main point right there. And then to exclude other things that we do like infection, special stains, et cetera, that sort of thing.
Right. There is another question about Langerhans cell histiocytosis, that how is it related to the neoplastic form of Langerhans cell histiocytosis? And if it is not, do you think that it is a misnomer in lung pathology?
Well, the thing about naming a lung disease, the second part of that question is there's lots of names that don't make sense. So I'm not really sure I can comment on that. But, well, we have say, leukemia-like Langerhans cell proliferations. Those are just Langerhans cells that have become, quote, cancerous. And in the smoking form, they're Langerhans cells that don't act like a cancer. So I wouldn't want to change the name simply because the lung is not a disseminated neoplastic process. The lung lesions can be clonal. They just don't act like a cancer. They more are like a, quote, reactive proliferation. Kevin, do you have any comment on that?
No, I think that's a great answer to that. Remember that Langerhans in its fibrotic phase can become a severe disease and kill patients. So we think of idiopathic pulmonary fibrosis as a lower lobe fibrotic dominant process that moves upward. Langerhans scarring is an upper lobe process that moves towards the lower lobes, and people can require transplantation. So it's not completely benign. For most people, it seems to heal with some residua. For some, we don't know whether they are completely normal after they stop smoking. But this idea of neoplastic transformation and malignant behavior are a broad topic, which we might address at some future presentation. But I think we can accept that we've got reactive Langerhans cell proliferations, we've got neoplastic, non-aggressive, non-spreading forms of Langerhans cell proliferation, and then we have the more childhood-associated Langerhans cell histiocytosis, which is more aggressive.
Like mast cell disease, there's some similar analogies. There's malignant mast cell disease, there's reactive mast cell disease, and there's mast cell diseases somewhere in between. But we'd have to get a card-carrying hematopathologist involved to really sort this out.
No, thank you so much. Actually, this was one of my curiosities all the time, that if in the lung you have LCH, which is related to smoking, and then many a times it goes away, then we have a very malignant process in the pediatric population, which is totally different, and we have the same name. So just a curiosity.
Yeah, no, that's true, and the commonality is a Langerhans cell, but in one it's malignant, and one it doesn't behave that way.
Right.
Interestingly, those neoplastic Langerhans cell proliferations in pediatric patients do look quite similar in the lung.
Right.
But they're very rare.
Right. Okay. There's another question. I think that's the last question that we have. What type of inflammatory bowel disease is more commonly associated with bronchiolitis? Is it Crohn's or ulcerative colitis?
Ulcerative colitis, but both can be.
Okay.
And that might be simply due to the fact that ulcerative colitis might be more common. I'm not sure about that. But in my experience, I think it's probably 3-to-1 ulcerative colitis, 4-to-1.
Mine too.
Right. I think those are the questions that I could see online. And thank you again, both Dr. Colby and Dr. Leslie, for this excellent discussion on pulmonary pathology. And I'm sure the viewers have found them very useful. I could see so many viewers who logged in from different parts of the world. I just can name a few. There are viewers from Mexico, Pakistan, India, Bolivia, Tanzania, Italy, just a few names that I could see quickly. And thanks to our viewers for your support. And Dr. Colby and Leslie will be back for their 5th lecture on non-neoplastic lung pathology. That would be on January 8th next year. Hope to see you then. And our next lecture is also coming up. So that would be next week on December 22nd. So we will have an obstetric pathology lecture, which would be on products of conception, molar pregnancies, and gestational trophoblastic disease. And our speaker will be Dr. Brett Quaddy from Brigham and Women's Hospital. So hope to see you then. And as always, please subscribe to our YouTube channel if you like our lectures, and follow our Facebook page. And don't forget to subscribe to the our newsletter as well. And thank you so much again, Dr. Colby and Leslie, for.
Thank you, guys. Take care.
Thank you.